It's on, Randall.
Hi, everyone. I'm going to give it a couple of seconds here for people to keep signing in, and then we'll begin. All right, good evening, everyone. My name is Danielle Angelari, and I'm the Executive Director of NAMI Northern Illinois. We're an affiliate of the National Alliance on Mental Illness, and we're dedicated to improving lives of individuals and families through support, education, advocacy, and hope. I'd like to read you an excerpt from our national headquarters as we begin tonight. What happens at the intersection of mental health and one's experience as a member of the Black diaspora? While the experience of being Black in America varies tremendously, there are shared cultural factors that play a role in defining mental health and supporting well-being, resiliency, and healing. Part of the shared culture experience, like values, family connection, expressions through spirituality or music, reliance on community networks and church, are enriching and can be great sources of strength and support. However, another part of the shared experience is facing racism, discrimination, and an inequity that can significantly affect a person's mental health. Being treated or perceived as less than because of the color of your skin can be stressful and even traumatizing. Additionally, members of the Black community face added challenges in accessing the care and treatment that they need. According to the the Health and Human Services Office of Minority Health, Black adults in the U.S. are more likely than white adults to report persistent symptoms of emotional distress. And Black adults living below the poverty line are more than twice as likely to report serious psychological distress than those living above it. Despite the needs, only 1 in 3 Black or African American adults who need mental health care receive it. Tonight, I'm happy to introduce you to my friend Jeanette Towns to give you some reasoning behind these facts. Jeanette is a 58-year-old mental health advocate and activist. She's a Rockford native, a mom, and a grandmother. Jeanette has a unique perspective on mental health issues as she was diagnosed with bipolar disorder in 1995, and upon recovery began work in the mental health field. Tonight, Jeanette will discuss her personal journey with mental illness and some of the reasons African Americans are reluctant to seek care, including historical and systemic barriers, shame, and stigma. If you have any questions for Jeanette, please hold them till the end of the presentation, and at that time, you can type them in the chat box or the question and answer box, and I will read them to her. Thank you all for joining us, and here's Jeanette.
Good evening. First, I'd like to thank you all for joining me on this journey. Next, I'd like to acknowledge NAMI for this opportunity. Tonight, I will discuss my personal story of navigating the world while having a diagnosis of bipolar disorder. I will then talk about a historical perspective on African Americans and the reasons why some shy away from healthcare. Lastly, I will tell what stigma and shame may cause a person to experience. My name is Jeanette Towns. I am a mother of 2 wonderful daughters. One is a nurse and the other is a business owner. I have 6 active grandchildren ranging in age from 2 through 12, 3 boys and 3 girls. I am an avid cook. I prepare meals for my family and friends on a weekly basis. I am very close to both my parents and my daughters, even though my father just passed, by the way. I am a mental health advocate and an activist. In 1995, I experienced some medical malpractice. I was then diagnosed with bipolar disorder. Prior to that, I had bouts of depression going back to my childhood. I didn't have a name for it back then. I just thought I was just sad. I was withdrawn at times as a child. At other times, I was able to enjoy a normal range of emotions. As I look back now, I can see that I was often anxious or fearful. I can remember a feeling of dread or doom. My family life was normal and was what I would consider void of trauma. My feelings of sadness, dread, or doom were all internal, not necessarily related to external happenings. As the medical malpractice occurred in 1995, I subsequently experienced my very first manic episode. I was in the ER having a small stroke, known medically as a TIA. I remember being lively and animated as I lay there. The doctor yelled out to the nurse, "She's unraveling." This first episode landed me in a mental health facility. I was offered a strong mood stabilizer. I was surrounded by my then husband and my children. I read the paperwork with the side effects. I respectfully declined. That facility shut down permanently a few days later. I was one of the last patients. Because of the closure, I was discharged with no follow-up care. What followed was for the next 7 to 10 years was no medicine, no treatment, and no clue as to what was happening to me. I was a disaster going somewhere to happen. My behavior was so bizarre that I actually frightened my family and my inner circle. I experienced wild mood swings. They ranged from manic to depressed and everything in between. One minute I was extremely happy, but moments later, I could be totally irritated by the smallest thing. I often was unable to sleep for days at a time. I would stay up at night cleaning things that were already cleaned. Music had to be loud. I began to dress differently, like I was a completely different person. On one occasion, I emptied out the family bank account on a trip to a casino. I was seemingly unable to stop gambling that day. I had many periods of hypersexuality. I exhibited risky behavior with multiple partners. I was homeless by choice a few times, leaving my spouse of 18 years and my children to live on the streets with unsavory characters. While manic, I divorced my first husband and married my second husband twice because I also divorced him while I was manic. I was in and out of jail, in and out of various hospitals, in and out of my right mind. During my last stint in jail, I was deemed unfit to stand trial. I was remanded to a state mental facility in the forensics unit. I was there for a 4 month stay. I was finally given meds that worked. While there, I took note of the staff. They cared for the clients. They were attentive. I decided that I wanted to work in the mental health field if they would have me. Upon my release in February of 2004, I began the difficult work of recovery. I faithfully took my meds twice a day under supervision of the local treatment facility staff. I had intensive case management. Upon recovery, I was offered a full-time position taking care of 8 mentally ill clients a day. Best job ever. After exiting the workforce, I began to hide my story due to stigma and profound shame. Last fall, I was strongly urged to tell my story publicly. As a result, I became a mental health advocate and activist. I joined NAMI at that time. I began to do public speaking. When COVID hit, my speaking switched to online. All of my family relationships have been restored. I help people through my private Facebook page entitled Eliminating Mental Health Stigma. I'm living a life of peace and fulfillment now. Now I'm going to talk and give you a little history about mental illness. Historically, medicine has used Black bodies without consent for its own advancement. Medical theories, technologies, and institutions were used to reinforce systems of oppression. I'd like to give some examples to you. First, the antebellum period from 1812 to 1861 is a time where Blacks were forced to participate in dissections and medical examinations. In this time period, dead Black bodies robbed from their graves were a continuous source of surgical and anatomical experimentation. Also during the antebellum period, the psychiatric diagnosis of drapetomania or runaway slave syndrome was created to diagnose and pathologize African slaves who fled their vicious slave owners. Second, during the Reconstruction era from 1865 to 1877, white American doctors argued that former slaves would not thrive in a free society because their minds could not cope psychologically with freedom. Next, the Civil Rights era was from 1954 to 1968. It included a time where psychiatrists used the concept of schizophrenia to portray Black activists as violent, hostile, and paranoid because they threatened the racist status quo. And finally, the Tuskegee syphilis study took place between 1932 and 1972. This study involved hundreds of Black men without their consent that were intentionally administered syphilis and denied treatment. This became the very embodiment of the way medicine and medical research was weaponized against African Americans. Can you even imagine this? Now we will move on to modern times. Despite trends in the reduction of racial prejudice over recent decades, the marginalization of Black Americans takes place at every level of the contemporary medical system. In one of many recent surveys conducted by researchers, African Americans feel they would be used as guinea pigs for medical research. Many times, African Americans' mistrust may be interpreted by a doctor as a symptom of mental illness and lead to a misdiagnosis of paranoia or paranoid schizophrenia. In turn, the fear of being diagnosed this way may prevent some African Americans from seeking treatment or being truthful with their doctors. There is differential treatment in the Black community. Black individuals are often seen as more dangerous. For example, some can be given a 4-point restraint as opposed to being sedated. Black individuals are also less likely to be prescribed newer, better tolerated medicines. One study of emergency room records indicates that the complaints from Black patients are more likely to be rated as less serious than even as false claims. Are we receiving bad medicine? People of color receive less care, often worse care than white Americans because of the things like lower health coverages, communication barriers, or racial stereotyping. Black men have the worst healthcare outcomes of any major demographic group, resulting from a legacy of discrimination. An example of this is the Tuskegee study still having a negative effect on Black families today. The life expectancy of Black men is more than 3 years less than non-Hispanic Caucasian men. This 40-year experiment led by the U.S. Public Health Service mentioned earlier tracked 600 low-income African-American men in Tuskegee, Alabama, 400 of which had syphilis. They were lied to about the study and giving placebo treatment, and by default passed the disease on to their families while their doctors watched the effects. Many individuals ended up ill or dying. This study revealed racism as opposed to pathology of syphilis. This is a large driver of documented mistrust in the health system by African Americans. Black men are less likely to seek treatment than white men because of the legacy of the Tuskegee study. Now that we've learned why Black men have the worst healthcare outcomes, let's discuss the case for the Black woman. A historical example of care for Black women I'd like to share begins with the father of modern gynecology. His name was James Marion Sims. He believed that Black women, particularly slaves, did not feel pain. Because of this, he thought that it was acceptable to experiment on slave women without anesthesia as they screamed and writhed in pain. When a lot of Black women are in labor today, they are left without epidurals or pain relief methods, whereas their white counterparts may receive more care. Today, Black women cannot prove that they are being discounted or denied treatment, but they have this persistent nagging feeling that something is amiss and they're not being treated the way that they should. Women in general and Black women in particular face unique challenges trying to be taken seriously and get their needs met by their doctors. Black women's perceptions of what's going on in their own bodies are often discounted, even if they're Serena Williams. According to an interview she did with Vogue, Williams was at risk for a pulmonary embolism and was experiencing shortness of breath after an emergency C-section. She recognized the symptoms and asked for a CT scan and a blood thinner, but the medical staff did not take her seriously. Blood started pooling inside of her, which eventually led to another emergency surgery. Are these examples of discrimination in healthcare? Black and other minority groups in the US experience more illnesses, worse outcomes, and premature death compared with whites. Why are certain groups of patients getting different care? One reason is negative assumptions and associations we can label as racism or an inherently racist system. Racism and discrimination are deeply ingrained in the social, political, and economic structures of our society. These differences result in unequal access to quality education, healthy food, livable wages, and affordable housing. Even doctors are sometimes the targets of bias and racism. A recent published report includes overt bigotry expressed toward doctors of Black, Indian, and Jewish heritage. Research has shown that Blacks are less likely to report trust in their physicians and hospitals, thus are less likely to seek treatment or be compliant with recommended treatment plans. Trust is a major factor in the well-documented health disparities between Blacks and whites. Trust is not only a foundational element to a doctor-patient relationship, but it is also a vital factor in a patient's decision-making to seek help early before diseases advance beyond the treatment possibilities. Now that we understand the historical and systemic effects of refusing care, let's discuss the impacts of stigma and shame that those living with mental illness face each day that compounds that decision. Stigma is the disapproval of or discrimination against a person based on perceivable social characteristics that serve to distinguish them from other members of a society. Social stigmas are commonly related to culture, gender, race, age, intelligence, and health. It can be internal or external. Some internal examples of stigma are feelings: shame, embarrassment, inferiority, feeling damaged, or feeling flawed. I've experienced all of these things at one point or another since being diagnosed with bipolar. Here are some thoughts. I don't want people to look down on me, to think less of me. I don't want to lose out on a new relationship. What will he think of me then? Will this prevent me from getting a job? What if my boss finds out? Well, I've personally had all these thoughts as well. When you experience bipolar disorder, you don't want people to look down on you or perceive you as being on a different level from them. I've experienced situations where I was at the beginning of a new relationship and I had to make a decision as to whether I wanted to tell my partner that I had a diagnosis. Because I was thinking, what will he think of me then? Is he going to just turn around and walk away? When a bipolar person or someone with schizophrenia is seeking a job, they try to hide their diagnosis for fear that they won't be hired in the first place. And if they do get hired, some of them wonder, what if my boss finds out? Pressure to hide the condition, to appear to be normal, to fit in, and to be the perfect friend, and sometimes walking on eggshells with the family. A lot of people, or myself, I would try to appear to be normal, or what I perceive to be normal, or what I think they think is normal. To fit in, I don't want to stick out. I don't want anybody to look at me as being anything different. I try to be the perfect friend, try to be attentive and caring and considerate of my friends. But at the same time, with my family, I'd be walking on eggshells, wondering if they thought I was going to go off the rails. Feeling judged. Even years later, when when you are well, you can still be treated different by your family, like being under a microscope. All of this combined together creates added stress and complications to an illness. Another type of stigma is external stigma. Okay, we're going to talk about media portrayal. One example is if you're living with a mental illness, you're a serial killer. Some examples of that are like the slasher films, the Mike Myers, the Jason, the Bates Hotel movie, the Chucky doll, and things like that. Just slasher movies, they're all portrayed as mentally ill. Another is living in an insane asylum. Some people feel that if you have a mental illness, you belong in an insane asylum. If you look at the movie One Flew Over the Cuckoo's Nest, you have one person sitting in a corner in the fetal position rocking. You have another person running around the room in circles screaming. You might have another one that's nonverbal and will just stare off into space. Then you might have a woman who's holding a blanket and she's not carrying a baby in it. These are Hollywood portrayals of people with mental illness. Bullying or teasing. If you have a mental illness and you're in school, for example, you could be teased or bullied by your peers if they find out that you're on medication. Did you take your crazy pills today? Or take a chill pill. Even physical violence, like getting beaten up and taunted. Sometimes Kids, like say in elementary school, will be told at noon when it's time for lunch, you come to the nurse's office, you line up, and you take your medication. If your classmates find out that you're doing that, they'll know that there's something different about you. And you might get taunted or teased or even beat up on the playground as a result. Nosy people. People wanting details about you just so they can gossip about you, not so they can help you or support you. That's self-explanatory. Toxic masculinity. Some men feel like they can show no signs of weaknesses and have to be brave at all times. Some men may feel if they show a perceived weakness, someone will attack them while they're down, or that women will look down on them because they look wimpy. Some boys are raised like that in the American culture. Now I'm going to discuss the C word. The biggest insult that you can say to someone with mental illness is that they're crazy. The word crazy brings up all kinds of negative connotations. It is derogatory and meant to hurt someone. Mental illnesses are not adjectives, and you should call people by their names. Don't label people, especially based on your own perceptions. It's not cool when you are with a group of friends and your friend says, "Girl, you so crazy." That's not cool. I've heard people say that in a joking manner, but there's nothing funny about it. Perceived weaknesses. It takes a strong person to navigate the world with a mental illness, but outsiders tend to look at you as flawed or damaged. For example, people with schizophrenia, their five senses operate differently. So if you find them having a whole conversation and they don't see anybody, sometimes they're looking at the TV and they're talking back to the TV, and sometimes the TV is even off. Um, in times past, they would look at the white screen that would come on at 2 a.m. and have a whole conversation with that. Some people with schizophrenia will be in a bedroom alone, and you're thinking that they're having a whole conversation with somebody, but there's nobody there. It's an internal dialogue going on inside their head. Just pray it away. A lot of religious people feel that prayer is the answer to everything, but there is a natural side that needs to be attended to also. For example, therapy and medication. People treat you like you don't have enough faith if you have a mental illness. It makes you feel like you have to hide your illness. I've experienced that where it's not so much taught that you don't have enough faith, but it's caught, and people say, just pray about it. Just pray about it. Well, that doesn't solve everything when there may be therapy needed or medication needed. Other religious reasons. Some religious people believe that you must be sinning in your personal life if you've quote unquote caught a mental illness. Okay, I'm going to discuss church face real quick. What I call church face is when you go to church, you put on a smile, you put your best foot forward, you hug people, you greet people, you smile. And when someone says, "How are you doing?" you say, "Oh, I'm doing just fine." And then you go home and cry because you're so severely depressed. So, can we fix this? Physicians have a 15-minute period to get patients in and out. Under pressure, you default to stereotypes as it is a mental shortcut. We all default to implicit bias. We use the term implicit bias to describe when we have attitudes towards people or associate stereotypes with them without our conscious knowledge. This can happen with any race of people. Everyone has a part to play in working on that part of themselves. This is a call to action. The call to action to fight racism and discrimination in the medical system is for all of us. Be honest about what's happening. We all need to recognize, name, and understand these attitudes and these actions. We have to acknowledge that gaps in healthcare disparities result from a myriad of other social detriments of health, such as educational level, employment, housing, community resources, and healthy eating. Schools of medicine can do its part in ensuring doctors are properly trained by integrating the concept of implicit bias into the medical education curriculums. The healthcare system must train doctors and all staff to see the patient who walks in the door as a person first. We must manage overt bigotry safely, learn from it, and educate others. We need to practice the model of tolerance, respect, open-mindedness, and peace for each other. Thank you. Does anyone have any questions for me?
Thank you, Jeanette. Yeah, if anyone has questions, please type them in the question and answer section or the chat box. I'll give you a moment. Eric, are there any questions over on Facebook?
Not at the moment, but if anybody has questions on Facebook, we're also monitoring there as well.
Thank you. I've gotten some thank yous for you, Jeanette. I don't see any questions yet, though.
Okay, I'll take a thank you.
I know you're looking forward to the questions.
Absolutely, I'm looking forward to questions.
I guess we'll wait a couple of minutes for questions, but do you want to tell people how they can get connected to your Facebook group if they're interested?
Okay, the Facebook page is called Eliminating Mental Health Stigma. It's a private Facebook page. You can put in a request to be a part of the group. You have to answer like 3 questions, and myself or my co-administrator, Latricia Russey, QMHP, will let you into the group. I talk about mental health issues. People can bring up personal problems that they're having with themselves or their loved ones concerning mental illness. There's just a lot of education going on in there, and it's a safe place for people to talk without it being on a regular Facebook page.
Awesome, thank you. Now I've got some questions for you. First of all, Jacqueline, yes, this presentation is being recorded. It will be on our Facebook right after this because we're on Facebook Live, and we'll put it on our YouTube and website to share if you'd like. First question from Christy. Has your family accepted your diagnosis?
Absolutely. For many years, we didn't know what bipolar meant because we had never heard of it before. So there was a lot of confusion in my family. There was a lot of what happened to her going on. And it took years for my family to get educated on bipolar as I was being educated at the same time. And I denied that diagnosis for many years because I just didn't know anything about it. So eventually everybody got educated and we all got on the same page. Everybody rallied behind me and I got the help that I needed.
Thank you. Ron asked, how did you know that you needed help? Like the very first time, maybe?
The very first time was during the period of the medical malpractice. And when I was in the hospital, when the doctor said she's unraveling, I was involuntarily committed to a facility. I didn't know I needed help because I didn't know anything was wrong with me. A lot of times when you have bipolar and you're in a crisis, you're the last one to know that something's wrong. So no, I had no idea I needed help. I thought the problem was with everybody else.
Thank you. Sue asks, what are you doing to advocate now besides
Right now,
your...
I'm using Zoom to advocate. Prior to COVID, I was doing a lot of public speaking, trying to help the mental health tax referendum be passed. I began to educate, and I began to use NAMI as a resource to get the word out. So when COVID hit, everything went virtual. So I get invitations to speak forums online now.
Thank you. What is the biggest thing that helps you day to day cope with and overcome your mental illness?
Right now, it's knowledge, education, and medication.
Sure. How do you suggest the healthcare system change, and where are some resources you suggest for nurses, doctors, and social service providers?
Could you read the first part of that again?
Yeah. How do you suggest that the healthcare system change? Like, how do you suggest that it changes?
The healthcare system?
Yeah.
I think that when doctors and nurses are in school, they need to spend more time being educated on mental illness. There's a lot of stereotypes out there. Even people in the medical field operate off of stereotypes. So if they had more of an education in mental health, they could treat their patients a lot differently. What was the second part?
Where are some resources you suggest for nurses, doctors, and social service providers?
For anybody, I would suggest NAMI as a resource. NAMI means the National Association on Mental Illness, National Alliance on Mental Illness. So NAMI is, to me, it's a large nationwide resource system where you can ask questions. You can go to support groups. There are some support groups led by people with a diagnosed mental illness. Some of them, you learn how to help your family members. And so they can just lead you in the right direction where you can get more help.
Thank you. So someone asked, is mental illness hereditary? Do you want to take that one?
I will take it and you can follow up. I believe it is. I've noticed different families where the same condition happened generation after generation after generation. But I've noticed in generations past, they didn't have a name for the disorder. You just knew that so-and-so was different. Back in the day, a lot of people with mental illnesses that were severe were kept in the back bedroom. They didn't come out. You just put their food outside the door. They would grab the food, close the door, and you might only see them once a year, maybe at Christmas. Then they would go back in their room. There was no therapy, there was no medication, there was no understanding. They just kept that person out of the way.
Yeah, for sure. And I'll give just a short answer. Short answer is yes, it definitely can be in your genes, but it's a combination of, biology, psychology, social factors, environment. It kind of all plays a role. When were you able to actually say I have bipolar disorder after your diagnosis?
Oh, about 10 years later.
Okay. Is that when you finally actually got the treatment that you needed? That
Yes.
10 years later? Yep.
Yes. And because 10 years later, I got some education, I realized that I was a textbook case of bipolar disorder. I mean, it was so clear that my face could have been in the dictionary.
Emily here says, I recently was diagnosed with having bipolar, and you're the last to know statement resonates with her. So thank you.
You're so welcome.
Latricia says, excellent job, by the way.
Thank you, Latricia.
I have another question here. What should law enforcement do to prepare and to be more effective in dealing with people with a mental health diagnosis?
Education, education, education. Law enforcement, if you're in a crisis and they come to assist you, they're often the least helpful. If they see you when you're manic and you're in a crisis, you won't be treated like it's the worst day of your life, but it is the worst day of your life when you need understanding, compassion, and help. You might get handcuffs in a jail cell instead.
Any more questions from anyone? Do you have any final thoughts for people? You did an awesome job, by the way.
Thank you, Danielle. I just want to thank everybody for tuning in, for spending this time with me, and for listening to my first solo seminar or presentation. I really appreciate and value your time. So I'm just going to end with that. Thank you.
Thank you. And like I said, everyone, you can see the video recording on our website, Facebook, and our YouTube. Jacqueline, there's a couple different education presentations in the works, but I will definitely keep it posted on our website and Facebook. So keep watch. All right. Thank you, everyone. I hope you have a good night. Oh, here's the resources, by the way. Thanks, Jeanette.
Thank you.